focuses on our and new awards installed from this year. I request our respected President-elect Dr. GVS Murthy Garu to release the special edition of newsletter and request the dynamic, enthusiastic editors of our newsletter, Dr. Nihal and Rufus, to give a brief note on it. GVS Murthy Garu, kindly inaugurate the launch the new edition.
Thank you, sir. Thank you. Thank you for giving me this opportunity, sir, President, sir. And good evening to all. And before that, I'd like to say a few things. And I'm very happy to see all our members taking active participation in all our society activities all throughout this year. And also, I would like to appreciate our communication team, mainly led by Dr. Rupert and Dr. Nihal, for their excellent work in bringing out this newsletter promptly every time. I congratulate you both. Thank you. Thank you for bringing nice newsletters. And also, I request all the postgraduates to become members of our IPS AP state body so that they can present their papers in our upcoming AP Psychon. So this time we are very strict and we are not going to allow any non-members to present their papers in AP Psychon. So please spread this news about the PG members becoming PG students becoming members of AP State, so that they will be able to present papers in AP Psychon. And also in this connection, I would like to mention that there is a new award instituted by Dr. Uday Kumar, and which is going to be announced in AP Psychon for the best scientific paper. So for all the details, people can log into IPS AP State Branch website and to find the details about this. Now I request to release our latest edition of newsletter. Thank you.
Ramya. Ramya. Okay.
Yeah. Janama? I'll correct it. That's a small issue. Yes, for me, it's
Nihal, will you speak on this something?
Sure, sir. Good evening, respected seniors and my dear colleagues. Today is the launch of our special edition newsletter. This edition is unique as it not only summarizes the events of the past year, but also speaks about the upcoming AP Psychon and the awards that will be awarded at the AP Psychon. First and foremost, I want to express my sincere gratitude to our esteemed President, Dr. IVL Narasimha Rao sir, and our Secretary, Dr. I. Sharat Chandra sir, for entrusting us with the creation of this newsletter. The freedom they granted has allowed us to craft a very comprehensive and informative piece. I would also like to extend my thanks to my co-editor, Rufus sir, whose invaluable support has been instrumental in bringing out this newsletter to life. This is the fourth newsletter from the communication team, and the next one will also be released at AP Psychon under the IVL Sir leadership. This newsletter serves as an informative resource for all the members of IPS AP State Branch as it reflects on the achievements of the past year, showcasing the work of our IPS AP State Branch. It also provides a glimpse into the exciting events that lie ahead, specifically the highly anticipated the AP Psychons conference. Of particular importance, this newsletter details the prestigious IPS AP awards. I would request each of you to take some time to explore our newsletter and encourage your postgraduates to participate in them. The East West Pharma will be distributing the hard copies of the newsletter to your respective medical colleges sometime later. Thank you very much for giving us this opportunity.
Now, I request Dr. Vishal to conduct the academic program.
Good evening, everyone. Warm welcome to all of you to this presentation on food addictions. It's indeed a very interesting topic chosen by the office bearers and the CME committee. Let me start by introducing our esteemed chairperson today, Ramana Rao Garu. After completing his MD in psychiatry from Andhra Medical College, he's won a lot of accolades. No need actually for a formal introduction for him, but he's one person who is still a very curious student, more curious than most postgraduates and most psychiatrists, I would say. He's also an international distinguished fellow of the American Psychiatric Association. He was the past president and I think the youngest president of the IPS AP state chapter when he was in his mid-30s. He was president of IMA Bhimavaram branch. He was also the chairperson of the Yoga and Meditation Subcommittee and also the subcommittee for the homeless persons with mental illness in various years. He's organized an international conference on spirituality in the year 2021. He received the prestigious Dr. D.S. Raju Oration Award in 21-22. Former associate professor at Ashram Medical College at Eluru. He is currently the member of the State Mental Health Authority and also he is currently working as the consultant psychiatrist at Shanthi Hospitals, Bhimavaram. That's his own proprietary family concern with his son, Dr. Subhash, and daughter-in-law, Dr. Srividya, who are both acclaimed psychiatrists in their own right, helping Dr. Ramana Rao Garu. Before I hand over, just a couple of words about the topic. In the US, there are already eating disorder clinics at this time. What child psychiatry was about 20 years back, I think eating disorders is currently in that stage. And I'm sure over the next decade or so in India also, we will have specialty clinics for eating disorders. That's my hunch. So the youngsters who are present here, there is no harm in digging much deeper into this subject and fine-tuning your skills in this area. There's a lot of research coming up on this area. I think, as I understand, food addictions is still not a part of DSM-5 at this time. The nearest category, if I may use that word, would be probably binge eating disorder. That is the closest DSM-5 category at this time in DSM-5 for this, because some of these food addictions do not have the full-fledged criteria like other addictions have, like withdrawal symptoms, for example, etc. might not be there. But I won't stand between you and the speaker and the chairperson. Dr. Swathi is a young and dynamic speaker, as I understand. We are all very interested to learn more about this topic. And now I hand over the proceedings to the chairperson of today's evening, Ramana Rao Garu.
Thank you, Dr. Vishal. Am I audible, sir?
Yes.
Yeah. Sure, for your very nice introduction. In fact, this topic on food addiction goes back when me and Vishal had been to APA, San Francisco, last May. At that time, in fact, I missed this talk on food addiction, and there is a lot of appreciation for this topic. Then I thought, why can't we do it sometime in our AP chapter? Before that, I would like to introduce today's speaker, Dr. Swathi. She has done her MBBS at Amalapuram KIMS Hospital, and then her MD in Psychiatry NRI, Mangalagiri. And now she's working as the Assistant Professor of Psychiatry at AMC, Vizag. And she has a certificate course in Child and Adolescent Psychiatry by ICAM of India. And coming to the topic proper, why I just thought that this topic should be introduced to our colleagues, both the young as well as the practicing psychiatrists, is because we know that according to the literature, more than even in India, there is a prevalence rates of 13% in the community, and more than 20% in the special groups like obese individuals who are attending the bariatric surgery, or even more also, around 40% also. So that is one thing. The other thing is there are certain instruments that were specially, prepared and specially they were validated. That is Yale food addiction scale. There are several versions, and I think Dr. Swathi is going to tell about it. And also, there are circuits which are almost equal to those of other substance use disorders, neurocircuits, and there is basic genetics involved. Why some people are more prone for food addiction, why others are not so addiction, including dopamine polymorphisms and then opioid polymorphisms, and even leptin opioid receptor polymorphisms. There are certain established studies also that some people are more vulnerable for food addiction. And as Dr. Vishal was talking about the eating disorders, there is a subtle difference between the eating disorders and food addiction, as well as the obesity. There is an overlap, but there are certain subtle differences which Dr. Swathi is going to, I think, elaborate upon. Apart from that, as far as the psychiatrists are concerned, as Dr. Vishal was talking about, maybe for the postgraduates, they might not find a diagnostic label in the DSM-5 or ICD-11, but definitely it's going to be one of the diagnostic entities in the days ahead, because the problem is huge, especially for psychiatrists. We have got so many atypical antipsychotics and mood stabilizers, and a combination of these drugs, polypharmacy, and most of our patients are becoming obese because we are starting these drugs much earlier. Especially the adolescent age group is most vulnerable population, and even pediatrician colleagues, they always talk about overeating in children and obesity also. So it starts early in the childhood, and it increases in the adolescence, and by the age of maybe 30s, 35s, especially in women, we find this more common. So it's our responsibility to see that our patients are instructed about the lifestyle modification, diet, and then exercise, so that at least they will be conscious of their weight gain, and they'll be preventing the future complications, because obesity is one of the major risk factors for the several physical health diseases, as we know: diabetes, hypertension, coronary artery disease, cancers, osteoarthritis, say anything, it will be there. So especially psychiatric patients, we see so many of our patients coming with so many comorbidities. And I think if there is a diagnostic entity like this, which I think it deserves, because they're almost like substance use disorders only, the neurocircuits and all that. So I think time that probably the various groups will work on that. And in the near future, I think there may be one diagnostic entity for food addiction also. So with this brief introduction, I request Dr. Swathi to go ahead with that topic.
Okay. Good evening, everyone. Thank you so much, Dr. Vishal sir and Dr. V Ramana Rao sir, for your warm introduction. I would like to thank IPS AP State Branch for giving me this opportunity. I'm going to share my slides. Am I audible, sir?
Yes, yes,
Is it visible?
yes, yes. You can
Okay.
go.
Okay. Today I will be presenting on food addiction and mental health perspective. This is my scheme of presentation. And then coming to introduction, the scientific use of the term addiction in reference to food in relation to chocolate has been traced back in 1890 in the Journal of Wiener and White. This was one of the first journals in relation to food addiction. The term food addiction was coined by Theron Randolph in 1956. Randolph had defined food addiction as a specific adaptation to one or more regularly consumed foods to which a person is highly sensitive. It produces a common pattern of symptoms descriptively similar to those of other addictive processes. In the past, addiction was reported to occur for foods like corn, wheat, coffee, milk, eggs, and potatoes. But of late, it is known to occur to high-density, hyperpalatable foods. Not all foods are equally addictive. Hyperpalatable foods containing high proportion of saturated fats, sugar, artificial flavors, or sodium have been associated with addictive properties. And why hyperpalatable foods have high addictive properties means because of underlying similar pharmacokinetic properties with drugs of abuse. That is concentrated dose and rapid rate of absorption due to the addition of fat or refined carbohydrates. This may explain the high addictive properties of hyperpalatable foods. Then coming to the prevalence, it was assessed by Yale Food Addiction Scale. Based on few studies, it has been found that worldwide mean prevalence of food addiction is around 18 to 21%. And prevalence was high in binge eating disorders, that is around 34 to 75%. And the prevalence of food addiction in studies conducted in India range from 13.3 to 32.5. Then coming to etiopathogenesis of food addiction, biopsychosocial model have a role in etiopathogenesis of food addiction. It is a complex and multidimensional disorder with a biopsychosocial pathogenesis. And this model contributes the interaction between biological, psychological, and social factors. Biological factors may emphasize the role of genetics, neurochemistry, and neurophysiological changes. And psychological factors are different personality traits, coping mechanisms, emotional states, all these influence the food addiction. And social factors like different socioeconomic status, cultural norms, and different food environment, all these leads to food addiction. And one more thing is, few studies have been stated that significant voluntary weight loss or voluntary dietary restriction may have a role in food addiction. That it increases the binge eating pattern. And one study, it has been stated that voluntary significant weight loss or dietary restrictions increases the binge eating pattern in 20 to 30% of participants. And stress, trauma, and early life adversities have a role in food addiction in lead to obesity and weight stigma. Then coming to nutrition transition theory, it describes a global trend towards consumption of processed food that are low in fiber and high in added sugars and fats. The changing global food landscape in the past few decades have increased the access to convenient snack foods and decreased the time spent preparing foods at home. Then this is Krieger's eco-social theory, which emphasizes the social production of disease over biomedical individualism. That is, individuals have, with the different socio-economic status, have different susceptibilities to diseases based on their unique life styles and unique life histories. So this describing embodiment of as biological incorporation of social and ecological circumstances into everyday life. Then coming to neurobiology, food intake is regulated by two complementary drives, that is homeostatic pathway and hedonic pathway. Homeostatic pathway governed by signals relating to energy demands, and hedonic is based on reward systems. These two systems are closely interlinked and both respond to metabolic signaling. Then coming to hedonic pathway, it considered strong evidence in rodents and human models now supports the theory that both drugs and foods converge on a shared pathway in the limbic system, that is mesolimbic dopamine pathway. The exact mechanism by which food stimulates dopamine signaling is unclear, but one of the possibilities is that during food intake, orexin neurons may be activated This stimulates the ventral tegmental area for dopamine neurons. This in turn sends projections to nucleus accumbens. So increased dopaminergic transmission by direct action on dopaminergic neurons or indirectly through the inhibition of GABAergic interneurons in the ventral tegmental area have a role in hedonic pathway. This is the schematic representation of how dopamine levels elevated during food intake. Later, hypothalamus receives inputs from nucleus accumbens through GABAergic neurons and also receives inputs from arcuate nucleus of hypothalamus through melanocorticogenic neurons. These have a role in hedonic pathway and reward system. Chronic drug use is associated with decreased basal dopamine secretion in ventral tegmental area and also decreased neuronal size. And it increases the activity of tyrosine hydroxylase. It is a rate-limiting step in dopamine biosynthesis and increases the transcription factor in striatum, that is cyclic AMP response element binding protein. It also elevates the transcription factor like delta phosphate. So increased levels of CREP and delta phosphate alter the neuronal responsiveness to dopamine signaling. So increasing delta phosphate levels in the striatum increases the sensitivity to rewarding effect of drugs and increases the incentive motivation. So it has a strong support that mice exposed to high fat diet for 4 weeks and then abruptly withdrawn to less palatable diet showed decreased levels of active CRP in the striatum up to 1 week after the switch. Then coming to how transition occurs from ventral striatum to dorsal striatum. That is from nucleus accumbens foreign shell to caudate putamen. This is a addiction cycle. Increased levels of CREB and delta phosphate levels increase the reward sensitivity. This leads to overconsumption of palatable food. So with repeated overconsumption of palatable food, person may experience as tolerance, withdrawal, and craving, and also social, emotional, behavioral difficulties. And also with repeated consumption of palatable food, the person may habituate to the hedonic properties of food. This leads to decreased liking and increased wanting. To overcome all these efforts, the person may self-medicate himself with the increasing consumption of food. This leads to compulsive eating or binging pattern. This in turn increases the impulsivity and diminished inhibitory control. Then coming to the homeostatic pathway of food intake, homeostatic control of feeding is concerned primarily with regulation of energy balance. So homeostatic pathway activates following depletion of energy stores in the body. Two important hormones in the homeostatic pathway are leptin and ghrelin. Then coming to leptin, as we all know, it's synthesized by white adipose tissues. Level increases in proportion to fat mass. So high level of leptin suppresses the food intake and stimulates metabolic processes. In contrast to leptin, ghrelin is a stomach-derived peptide whose levels increases in response to negative energy balance and stimulates food intake and energy stores. So in homeostatic pathway, it has also affect the hedonic drive for food and activates the reward system. Then coming to effect of stress and feeding. As we all know, chronic stress induces dysregulation of HPA axis and increases the levels of stress hormones, cortisol, and increases the neuropeptide insulin. It induces dysregulation of reward system and increases craving for palatable food. And stress-induced elevation of ghrelin not only may alter food intake, but may also help to compensate for deleterious effect on stress, mood, and motivation. The various actions of ghrelin appears to be mediated by action of orexin neurons from the natral hypothalamus. Then coming to brain-gut microbiome, it has a bidirectional communication in which brain-gut microbiota axis, gut microbes communicate with brain and in brain communicate with microbes. So altered levels of gut metabolism leads to increased levels of insulin, neuropeptides, and also ghrelin levels. Increased levels of ghrelin also activates the hedonic pathway and reward system. Food addiction is associated with changes in brain-gut microbe interactions. It titled towards the hedonic mechanisms. Then coming to opioid signaling, endogenous opioids also have a role in reward system. It leads to higher levels of striatal dopamine levels, and it increases the desire for palatable food, especially foods that are already preferred, that is foods which one likes. It reinforces an already established hedonic value and plays an important role in reward system. There are certain hedonic hotspots in our brain. Those are medial shell of nucleus accumbens and ventral pallidum have a role in controlling opioid signaling. Then coming to food addiction is a complex disorder. It have a complex entity. It includes the clinical component of substance use disorders, impulse personality traits like lack of control, overfeeding, impulsivity. Food addiction symptoms have been associated with this. And it also having properties of eating disorders like impulsivity and intrusive thoughts of food. And this also leads to some somatic, psychological, and social dysfunction. Psychological, like it also leads to depression, anxiety, and somatic, like increased obesity, lead to stigmatization and all these things. Then coming to addiction model of obesity. In 2003, obesity was declared as a global epidemic WHO in both developed and developing countries. So one of the most common cause of obesity is environment, and one of the second most common cause is availability of high palatable foods. 3 mechanisms have been suggested in the pathogenesis of obesity are reward system, impulsivity, and emotional dysregulation. And about reward system, I have already mentioned in previous slides. And impulsivity is a reflection of executive control deficiency. It favors the short-term rewards of food, that is drugs instead of long-term benefits. And it correlates with the decreased activation of medial prefrontal cortex and other executive control regions. Then coming to emotional dysregulation, it precipitates the drugs, use of overeating and consumption of foods high in fat or refined carbohydrates in response to emotional states like negative emotions. Then coming to similarities between food addiction and other drugs. So external cue control of desire including specific appetite is similar to that of drugs. That is exposure to cues like sight and smell of food or cues previously associated with eating increase the desire to eat and appetite behavior, which is similar to that of other substances like in which external cues increases the desire for food and in turn it acquire incentive salience. Then coming to appetizer effect, which is similar to that of priming. Appetizer effect is appetite comes with eating. That is experience that the first mouthful of your liked food increases the motivation to eat is similar to that of priming. In other substances, like in long-term abstinence, drug users, if they take small amount of food, it increases the desire for substance. Then coming to disinhibition of dietary restraint is similar to that of abstinence violation effect of other substances. And coming to tolerance and withdrawal, there are certain animal models which have been explained about tolerance and withdrawal, but there are very less evidence for human models. And binge eating of food is similar to that of binge eating of drugs. And liking and wanting, as I have already mentioned, how it transition occurs from impulsive to compulsivity is similar to that of other substances. Reward deficiency in obesity also similar to that of others reward deficiency in other substances. Then coming to food addiction and eating disorders. Eating disorders like bulimia nervosa, binge eating disorder, and Prader-Willi syndrome include compulsive food intake as a part of clinical syndrome. Recent work has raised the possibility of aberrant mesolimbic dopamine signaling involved in these disorders. The exact mechanism of abnormal limbic activation is not known, but may involve alteration levels of peripheral feeding hormones. In peripheral hormones, like in reward system, ghrelin has a role in Prader-Willi syndrome. The pathophysiology of other disorders may have genetic, environmental, and psychological factors. Food addiction overlap with eating disorders, especially with binge eating and bulimia nervosa. Although binge eating pattern are found in both food addiction and binge eating disorders, grazing is a pattern of eating that is seen in especially food eating. That is a repetitive and unplanned ingestion of food throughout the day or period of time. And patients with binge eating tend to experience shame and guilt, which is not seen in food addiction. Then coming to food addiction in other psychiatric disorders, in major depressive disorders, the prevalence is around 25 to 28%. The first possible mediator of depression weight gain link is emotional eating, that is eating in response to negative emotions. Emotional eating may be a marker of this atypical depression subtype. Emotional eating and association between depressive feelings and further weight gain may be related to genetic predisposition. That is one candidate gene mainly responsible for this in depression is 5-HTT-LPR. In adolescents with depressive feelings shows more increase in emotional eating if they carried 5-HTT-LPR genotype that results in lower serotonin activity. HPA axis also have a role in depression by reducing glucocorticoid sensitivity. Then coming to food addiction and anxiety, few studies have been reported that food addiction and emotional eating were each positively associated with irrational beliefs in few studies. The only significant pathway indicated that irrational beliefs increased trait anxiety, which in turn increased emotional eating, and finally led to high number of food addiction symptoms. And antipsychotics and metabolic syndrome, atypical antipsychotics targets hypothalamic melanocortin 4 receptors to cause weight gain. This melanocortin 4 receptor expressing neurons in the paraventricular nucleus of hypothalamus directly regulate food intake. So, especially atypical antipsychotic risperidone have a role in decreased melanocortin receptor expression and reduced neuronal activity, leads to hyperphagia, metabolic side effects, and obesity. Then coming to food addiction in children, there has been limited research on food addiction in children. Children may be at greater risk than adults for experiencing adverse consequences as the neural and psychological systems are still developing. A consumption of potentially addictive foods like candy, cakes, sugars is more likely to occur during early childhood. The prevalence of food addiction in children and adolescents was between 7.2 to 29% in few studies. Again, biopsychosocial approach to childhood obesity should consider the biology of child, family environment, and immediate psychosocial influences, social and cultural influences. The role of stress, trauma, and early adversity, particularly early in the life, has been identified as a contributing factor in both drug and food addiction in child and adolescents. Early childhood adversity can induce long-lasting alteration in glucocorticoid and dopamine systems that lead to increased addiction vulnerability later in life. It is possible that the elevated food addiction in children relative to adults may be related to developmental differences and less development of executive control functioning, that is inhibitory control, planned action than in adults. Few models implicated in familiar pattern, that is including genetic contributions, prenatal exposure to substance, parental modeling of substance, and access to substance in child's environment. Although high palatable foods may have lower addictive potentials than other substances, the repeated consumption of these foods early in development may increase the risk of deleterious outcomes. So it is very important to understand whether food addiction may occur in childhood and its association with other eating related issues. Then coming to the management. Food addiction is a complex multidimensional disorder with intricate biopsychosocial pathogenesis. Therefore, it requires an integrated therapeutic approach consisting of psychotherapy, pharmacotherapy, and social-oriented support. Then coming to the structural assessment, various questionnaires are used to assess the food addiction and its related behavior. Yale Food Addiction Scale and Yale Food Addiction Scale 2.0 updated version, and Yale Food Addiction Scale for children, Addiction Like Eating Behavior Scale, and GQ, Gazing Questionnaire, Repetitive Eating Questionnaire, and Short Inventory of Grazing. These are various questionnaires used for food addiction. Then coming to Yale Food Addiction Scale, it was created in 2009 based on DSM-4 criteria for substance dependence. It contains 25 questions which addresses the food eating habits for the past 12 months. Then coming to AIL food addiction scale 2.0, it updated after the publication of DSM-5, contains 35 items. And modified version of MFYAS was created for administration in large epidemiological cohorts. Then coming to therapeutic strategies, lifestyle modification is very important in controlling food addiction. Psychotherapy, pharmacotherapy, social interventions, and less evidence for neuromodulation techniques. And among psychotherapies, CBT has strong evidence compared to other psychotherapies like interpersonal, dialectical behavioral, and behavioral weight loss and self-help groups. And pharmacotherapy has less evidence in food addiction. Social interactions and neuromodulation techniques among these, and neuromodulation interventions has less evidence. Then coming to cognitive behavioral therapy, it is effective in treating food addiction. It focuses mainly on replacing dysfunctional eating behavior with normalized eating patterns by critically evaluating thoughts in various situations, identifying the triggering factors like especially external cues, and developing positive coping strategies. Several cognitive biases result in increased motivation to consume substances such as attentional bias, affective and approach biases. Attentional biases, especially in relation to external cues, and affective bias in relation to mainly focusing on the negative information than the positive information. So we need to identify these biases in food addiction in cognitive behavioral therapy. So cognitive interventions such as response inhibition training, that is inhibition of response towards unhealthy food, and evaluative or effective conditioning targeting. This mainly focuses like a transfer of feelings from one set of items to another. For example, how in advertisements with visual and auditory content generates the positive feelings. It is similar to that. So it would be effective in management of food addiction. Then coming to pharmacotherapy, it has very less evidence. There are no well-studied pharmacotherapies for food addiction as it is not a recognized diagnosis. Antidepressants decrease frequency of binges in short term. Anti-epileptics medication decrease both frequency of binges and promote weight loss. But very less evidence for anti-epileptics like topiramate. It reduces just weight loss, but it has very less evidence. Then coming to naltrexone and bupropion combination, it is found to be effective based on few studies. SSRIs have been utilized in treating binge eating disorders, and stimulants are useful in binge eating disorders. And 2-HTC receptors agonist like lorcaserin is used for obesity, useful for it reduces the weight gain. Since food addiction, obesity, and eating disorders are interrelated, they are aggravated by other psychological issues such as depression, anxiety. So we should identify these risk factors and should be recognized and addressed. Then coming to psychobiotics, early probiotic supplementation is very essential for patients who underwent bariatric surgery. A double-blind RCT conducted on 101 patients who underwent gastric bypass surgery found that early probiotic supplementation after surgery decreases symptoms of food addiction and binge eating patterns. And restricted calorie diet along with probiotics have an important role in food addiction. Then low carbohydrate ketogenic therapy can be used as a metabolic treatment for ultra-processed food addiction and binge eating patterns. And coming to self-help group, it is similar to that of Alcoholics Anonymous, but however, it is not known to what extent it works in the management of food addiction. And Overeater Anonymous and Watchers Internationals are self-help groups emphasizing the psychological and spiritual component are behavioral strategies that provide framework for developing positive, adaptive, and self-nurturing modalities to cope with eating disorders and obesity. Then coming to social interventions, avoidance of triggers like external cues for food consumption that may be included in the daily routine. Eating only when someone is feeling hungry, that is using 0 to 10 point scale from starvation to overeating may be useful in grading the need to eat. And improving the emotional control, regular physical exercises have a role in preventive measures. And food addiction, preventive strategies and potential policy implications. Early intervention measures include incorporating programs, promoting healthy food choices and eating habits, greater regulation of pleasurable foods in child and youth settings, and engaging family physicians and pediatricians. Then coming to macro-social interventions. Specific policy interventions that can be applied for food addiction are it reducing access to addictive foods through the restriction of junk foods and fast food outlets, and food taxations, limiting advertisements for addictive foods. These have a main role in macro interventions. And government few regulations and marketing for unhealthy foods to children, especially prohibiting advertisements in children's television channels and mobile phone applications, have a role in preventive measures. Prohibiting the promotion and sale of such foods inside schools and displaying front of package warning labels have a role in preventing. Then there are a few arguments for and against food addiction. Towards the points which favors the food addiction are they may be addictive as for similar to other substances, and they may be a common neuropathological background for both behavioral and substance related addictions. The points against food addiction are no diagnostic criteria have been validated to good quality clinical or epidemiological trials. There is a high degree of comorbidity between obesity, binge eating disorders, and food addiction. And drug of abuse are acutely activating dopamine reward system, while foods are only slowly stimulating the system. And few points negatively interact with its nosographic validation are eating is considered a physiological behavior. Therefore, distinguishing pathological aspects from culinary preferences is difficult in certain circumstances. And risk to stigmatization, socially and culturally accepted behavior as being abnormal is challenge for mental health professionals, especially if there is no clear-cut diagnostic criteria exist for this disorder. It is not conceivable to formulate as a therapeutic object to for patients a complete abstinence is in case of other behavioral addictions. There are no evidence-based therapeutic guidelines and no clinical or lab examination for maybe used as definitive diagnostic methods. And there is high degree of overlap between obesity, binge eating, and bulimia nervosa, and separating them solely on clinical basis is very difficult. Then coming to conclusions, food has the potential for producing rewarding and reinforcing effects similar to those of drug of abuse. However, evidence for specific foods being addictive remain limited. And understanding obesity from a purely addiction model may be reductive. There is more evidence for cognitive behavioral therapy. And evidence does point towards the existence of food addiction, but more study is required to validate the concept of food addiction. These are my future directions. Although the research on food addiction is increasing, it is still in the nascent stage. So clear conceptualization of food addiction is required, including it as a diagnosable psychiatric disorder in ICD-10 and DSM for classification systems would propel the research in this field and optimize the management strategies. So these are my references. Thank you.
Nice that Dr. Swathi has finished it in time and very lucid presentation with most relevant information. And she also mentioned about the pros and cons for the concept of food addiction. Of course, she dealt very elaborately on the neurobiology of reward systems and the biological basis of food addiction. And she has mentioned a lot about the therapy, especially the role of psychotherapy, CBT, and all that. But the one thing which I could understand is that the basic counseling about lifestyle modification and the role of diet and exercise is as good as any pharmacotherapy for these food addictions. That's one thing which is proved in some of the meta-analytic studies. So the point that we have to take home is that every patient that comes to us, they need not have the eating disorder component, but most of our patients, they're getting addicted to the foods because of the medicines which we prescribe, the polypharmacy. So we need to educate them about the need to curtail their foods, especially the carbohydrates, high carbohydrate diet, and the junk food, which is freely available everywhere. So these are the points probably which we need to stress upon our patients, because even though it's not there in the diagnostic systems, but practically any mention about curtailing the food and the importance of the exercise for each and every patient is very, very important. So now it is over to Dr. Kishore for any of this question answer session. Kishore, are there any questions? I think Kishore is there in the line.
Kishore? Kishore?
Anyway, I will read the questions. What is the relation between the brain-gut microbiome and the reward system? I think this she has already answered. No, please answer once again.
Sir, brain-gut microbiome has a role in food addiction and reward system that altered levels of gut metabolites, micro-related metabolites, increases the levels of insulin and neuropeptides in gut. It increases the ghrelin levels. Those increased levels of ghrelin activates the homeostatic pathway. In turn, it has a relation with hedonic pathway in reward system. So brain-gut microbiome has a role in activation of reward system.
Second question is there any role of the shared vulnerability in obesity and the addiction?
Yes, sir. The role of shared vulnerability is there in obesity and substance abuse. Like few alleles as a role, like dopamine receptor allele tag DAQ1 and a few mu opioid receptor genes have a role in both substance abuse and obesity. So there might be a shared vulnerability. And one more thing is family history of alcoholics. In patients with family history of alcoholism may increases the binge eating patterns and obesity. So there might be a role of shared vulnerability in eating disorders and substance use.
Then difference between food addiction and eating disorder. That is an important question.
The main differences are in binge eating disorders. There is more concerns about body weight and body dysmorphism, and in binge eating is there in both food addiction and binge eating patterns. But only thing is that grazing thing and prolonged periods of eating without relation to appetite and satiety, that will be seen in food addiction.
What about the guilt?
The guilt will be more in binge eating disorders, sir, when compared to food addiction.
Yeah, that's right. Next, Dr. Bharati Challa, she asks about, she compliments. It's a novel topic, well presented, Dr. Swathi. Can you talk a little about how CBT and response prevention helps food addiction?
Thank you so much, ma'am. And CBT has a role, and we need to identify external cues related to food addiction, and we need to identify some cognitive biases like attentional biases towards external cues and approach biases. So we need to identify, and that should be addressed. So these biases plays an important role in CBT. So, in one more thing is you asked about response inhibition. So, response inhibition towards unhealthy food can be, it should be possible only with CBT. So, CBT has an important role in food addiction.
Dr. Jahanavi, she asked about any withdrawal symptoms in food addiction.
Sir, there have few studies have been reported that in animal models, not in human models, but in animal models, few studies have been reported that identified a few withdrawal features like fat binging, fat addiction, sugar addiction, fat binge addiction, but there is very little evidence for human models.
Prasad Rao, please go ahead, sir.
First of all, I would congratulate the Indian Psychiatric Society, Andhra Pradesh State Branch for bringing the young minds and the way they present and all. And Swathi is no exception. Congratulations, Swathi.
Thank you, sir.
But I might have to take a few, I would say, hedonic points on trying to understand the topic. The topic is very interesting, as you said, as a chairperson is saying, food addiction. Now I'll go back to the best review. And before that, in psychiatry, most of the times the phenomenological diagnosis is important. And here, the only similarity, and this I would go back to DSM-4. In DSM-4, that is about a decade and a half back, I would say between 90s and 2006, there were a lot of articles comparing food addiction. And interestingly, the experimental animal studies also happened at that time. The neuroimaging studies came in this decade, last decade, I would say, that is between 2011 to 2020. The only similarity is that there is a dopamine. There are other opposite authors, and one of the most beautiful study, I would say, is done by Adrian and Ashley. Adrian and Ashley in 2014 actually presented the dynamics. They said in DSM-4, the food addiction, now I'm using the word food addiction, and definitely not the other eating disorders. In food addiction, there is a similarity, but they went on to argue and prove that food addiction is probably a misnomer. Having said that, DSM-5, I'm privy to, I met both Adrian and Ashley in some of the meetings in WPA, in the eating disorder group. And the interesting take-home point is, DSM-5, there are at least 8 meetings. DSM-5, there are 8 meetings to look into the evidence of food as an addiction. And they couldn't find. That's why in DSM-5, you don't find, among gambling disorder has come into addictive disorder, but not the food addiction. That is the take-home point. But having said that, Swathi did argue in the last concluding points on the 2 important things. And for me, as a psychiatrist, there are 3 important components in this topic. One, of course, the binge eating. There are 3-4 other things which are symptomatic. Like, I would like to eat only laddu. I don't like to eat gulab jam of Kakinada or the West Godavari Putareku. I only eat each day 1 laddu. That is also considered as one symptom as well. Likewise, that is one single food you prefer. That is still, that doesn't qualify for the addiction because 1, there is no craving. Second, there is no withdrawal symptoms. For basic addiction disorder, there should be a craving and withdrawal symptoms. And unfortunately, in most of the food. The second, I think Swathi did argue very wonderfully on the association between eating disorder and others. And I might add, dopamine is not the main culprit. Insulin is the culprit. And that's what the most recent evidence is coming now. So I would like the youngsters, I mean, here, whatever I'm talking is just coming out of my thoughts. So food addiction probably is a misnomer, and it's not there in ICD-11. It's not there in DSM-5, the 2 important classifications which we have. But as a variance of food eating disorders, we do have well established. And I think Swathi has reminded me that the Indian group of eating disorders, there is one very small group of people who are working on eating disorders. They say, and they have found out, like in the West, anorexia actually precedes binge eating. So these are my thoughts. And of course, symptomatic treatment, and I think G.V. Ramana Rao did bring out the issue of atypicals, some of the atypicals being contributing to the eating disorder. These are my thoughts. I would think eating addiction is still not an established entity as of today, and probably DSM-6 if it comes with more. And I've been following the eating disorders for some time. I'm in the eating disorder group of WPA, so I know what the intricacies of. And I might tongue-in-cheek add, if some of you might want to know, in 90s, 80s and 90s, homosexuality removing lobby was there in APA. I think Raman Rao might know, and some seniors know. So that lobby became so powerful that they finally proved to the government that homosexuality is indeed a normal variant. So that kind of a thing as in eating also can happen. But because we are body conscious, but obviously we know very well that obesity is a precursor of a risk factor for all the medical disorders and many a psychiatric disorder. Thank you, Raman Rao Garu, for giving me the opportunity.
Thank you, Dr. Prasad Rao, for your very elaborate thoughts. There is one more question, Dr. Swathi.
Sir.
It was a great presentation, ma'am. And as food is being taken daily and as a routine activity, but how come it can become a compulsive behavior? Yeah, somebody anonymous, certainly.
Okay.
So he says, how can it become a compulsive behavior? Because we're taking it daily, no? And
Yes.
what he says, he or she.
Yes, sir. That's why I have mentioned in conclusion that it's very difficult to maintain complete abstinence in food addiction, as in other substances, but it has a role in transition from impulsive behavior to compulsive through repeated overconsumption. The person may habituate to hedonic properties, but because of that, he may develop decreased liking and increased wanting. So repeated overconsumption, the person may habituate to its hedonic properties, and because of that habituation, he may develop increased craving for food, and that leads to that leads to increased craving and decreased liking, and this leads to compulsive behavior, sir.
Thank you very much. Now it's time for the organizers to close the occasion. Thank you, Dr. Swathi, for your excellent presentation. And I thank all the participants for their excellent participation. Thank you. Also, Dr. Kishore.
Sure.
Sir, vote of thanks. So, good evening, everyone. It's my pleasure to present vote of thanks on this occasion. Our special thanks to today's speaker, Dr. Swathi Garu, for enlightening us with this new topic. Hope that this in future, this topic will be further topics are going to enlighten us much. And our special thanks to GS Murthy Garu for opening this brochure, and special thanks to Nihal and Rufus, who have really made a very good brochure. They have been very hardworking for the past 1 year, doing very good job. We thank you, sir. We thank you, Rufus sir and Nihal. And special thanks to Dr. Vishalinla, who has introduced the chairperson. And our heartfelt thanks to Ramana Rao Garu, who has chaired this session. Special thanks to all the office bearers and the executive council EC members, and all the attendants, all the participants who have joined this session and made it successful. Not the least, we thank East West Pharma for sponsoring this CME. Thank you, everyone.
Thank you all. Now over to Sharath.
Thank you, sir. Good night, sir.
Good night. We'll conclude this session. Thank you very much.